Hello, I'm Holly Potter with Kaiser Permanente. Many of you may be familiar with me or familiar with the organization as a nonprofit health plan and care delivery organization. We serve 9 million members across the country. In addition, given the makeup of this room, I suspect many of you are familiar with our use of information technology. We have one of the largest electronic health records in the world, with more than 9 million members being cared for daily through the use of an electronic health record, and they have access to that data through a personal health record on kp.org. But what many people are not aware of is we are also one of the largest non-university-based research institutes in the country. We have research institutes in each of our 9 operating regions and produce and actually conduct about 2,000 studies per year. In 2012, we published 1,000 studies in peer-reviewed journals. As a learning healthcare organization, we believe that research is critical to improving our clinical practice on a day-to-day basis. And as many of the folks in this room have talked about this morning, there is an acknowledged gap between the evidence and practice that each patient and provider are faced with each and every day. We are very fortunate. I'm sure many of people in this room were influenced by the 2003 findings of Elizabeth McGlynn that demonstrated just how stark that gap between evidence and practice was. She is now part of the Kaiser Permanente Research Institute. She is leading our Center for Effectiveness and Safety Research, helping us look into how can we more effectively translate research into practice and speed the discovery of what works and what doesn't work for each individual patient population. Now, as the introduction earlier noted, I'm a communications person. I'm in brand communication at Kaiser Permanente. I am not a researcher. I am not a doctor. My job is to help various publics, ranging from our workforce to our members to other stakeholders like those in this room, better understand what Kaiser Permanente does for the sake of advancing health research and transforming health care. And as I look at that role, I think one of the things that we have struggled with is helping not only our patients, but actually our providers understand how critical that intersection is between day-to-day practice, our electronic health information, and the research that can result from that, and then ultimately translating that research into practice. This is not a simple concept, and it does not come naturally. So helping people better understand the benefits is one of the objectives of the team that I lead. One of the projects that I wanted to share here today that had some really specific findings about some of those gaps in knowledge is a program called the Research Program for Genes, Environment, and Health. In 2005, we began an endeavor to go beyond the information in our electronic health record and actually begin to systematically collect DNA data from our members. We set a very bold target of 500,000 DNA samples so that we could begin to analyze longitudinal health data, genomic information, as well as the environment that our patients live in. We're very fortunate as an organization that we have members who we often refer to as sticky. They're particularly in our regions like Northern California, Southern California. It's not unusual for a member to be with us from the day they are born to the day they die. And because we were an early pioneer in electronic health records, we actually very often have 40 years or more of clinical information about the patients that we serve. We see that as an opportunity to really dive deeply into better understanding the clinical outcomes that those patients experience. But because some of our patients are also not very mobile, they're not moving from one city to another very frequently, we have patients who have lived in the same city in, for example, Richmond, California, since the days of the shipyard when our health plan was created, and still live there today. what would it mean to analyze their clinical data, their genomic data, and the environment in which they live in to better understand what really influences the clinical outcomes that come to be. So as we began the process of trying to recruit members to donate DNA to this effort, we began with the way everybody does. We sent a letter, very old school. We sent letters to every member in Northern California. I was one of the people who received them. And I actually was someone who knew about the study, knew about why we were doing it, and I immediately filled out the first survey and said, I want to do this. I want to participate. I was part of the 25% response that we got back of people saying, I'm very interested in this. Then I got the second packet, which was all the IRB consent forms. I'm fairly well educated, fairly well informed. They were hard to understand. And it took quite a while to fill that out. And I had to fill that paperwork out, submit it, send it in before I could even get the ability to basically spit in a cup and send my DNA back to the lab. By the time we went from the 25% of people saying, absolutely, I'm interested in this, I care about this, I want to participate, by the time people went through the actual consent, that dropped down to 5 to 7% response within that 25%. Fortunately, we have a very large group of people to start with. So to date, we have collected 200,000 DNA samples. We have done genotyping on 100,000 of those samples for an NIH-funded study. But we also recognize that of those that were returned, it was a self-selecting group. And we had a very high percentage of predominantly white women, 40 or above, which does not lead to a lot of actionable data if one of our stated intents is to look at the environmental and demographic factors that may be creating health disparities, which is one of the core objectives of this study. So we had to take a step back and really look at what was it going to take to bring in a more diverse set of data. We've tried a couple of things since then. We've done email recruitment, and that increased outcomes a little bit. We were able, through kp.org, which is our personal health record, to change opt-in features so that people could start receiving requests for participating in this study via email. We have also done clinical interventions. We specifically tested it with pregnant women, and we were able to find an uptick in participants by that doctor-patient conversation. And that also, while it shows promise, is also very complicated, because if we're looking holistically, number one, doctors don't need another thing on their list to do in their very short time period with their patients. But in addition, if we want to look holistically at the populations and what is or is not causing clinical outcomes, we need to be looking at young and healthies and people who aren't actually coming into the clinic for services. So we are looking at new strategies for reaching those populations, and particularly have identified a gap in young men of color who we have not been able to reach through traditional mechanisms. So moving into 2013, we're looking at increasing digital strategies for communicating with those populations and recruiting them to be part of these studies. Overall, as I noted earlier, these are complex subjects, and getting people to understand not only that they're doing something altruistic for the better of science, understanding that there is an easy in to participation is one of the challenges that we continue to struggle with because of the regulations and expectations of all of the various consent processes. So communications will continue to be a critical piece of this intervention and this effort, but we are hopeful that as we begin to publish information and demonstrate the value of this data, we'll be able to continue to recruit people into this program so that we have the data necessary to do really groundbreaking research. Thank you.
Thank you very much, and please join me in thanking the panel, and we're getting closer to getting back on time. So if the folks in the audience have questions, if people on the webcast have questions and you'd like to send those in now, we're ready for you.